Great, thank you. So welcome to the fall PMT session here at SWOG in Chicago. I'd like to welcome everybody in the room. There's a big color there right in the middle, and people on the Zoom call. So we have a big full agenda. We're going to talk about the active protocol and do the updates, and then the pending trials. And so there's a lot to talk about today, and we hope that, again, any questions that the people on the Zoom have, we'll enter it into the chat box, and we'll try to address those as we go through. So first, Dr. Chabra is going to talk about SWOG 1803, the phase 3 intergroup, DARA plus LEN versus LEN after autologous stem cell transplant for multiple myeloma. Welcome, Dr. Chabra.
Thank you, Dr. Steve. Thank you so much for the opportunity. I hope you can see my slides.
Yes, we got them.
Excellent. Thank you. So my name is Saurabh Chabra. I'm at Mayo Clinic, Arizona right now, and I'm here to provide you an update on the SWOG S1803 clinical trial on behalf of my colleague and co-chair, Dr. Amrita Krishnan. S1803, as you know, is a phase 3 randomized trial investigating single-agent lenalidomide versus lenalidomide plus subcutaneous daratumumab regimen as maintenance therapy following autologous transplant for multiple myeloma. Adult newly diagnosed myeloma patients up to 75 years of age who are within 18 months of starting induction therapy and without progression at any time since diagnosis are eligible for this trial. This trial has 2 randomizations. Patients are to undergo first randomization to LEN or LEN-DARA within 180 days from autologous transplant. MRD is assessed using next-generation sequencing on the clonoSEQ platform prior to the start of maintenance and then annually. And the randomized treatment is to continue for 24 months, at which time point patients who are MRD negative at less than 10⁻⁻⁶ undergo second randomization to either continuous maintenance on their assigned arm or they discontinue maintenance. I will skip this slide in the interest of time. The primary objective of the study is to compare overall survival between LEN and DARA as the experimental arm and single-agent lenalidomide as the control arm. The objective of second randomization is to compare overall survival of MRD negative patients who continue maintenance on each arm versus those who discontinue. And so an early readout of the trial will be the 24 months MRD analysis, which will be as early as 24 months after all patients have been accrued. And here's a timeline of important milestones for the trial. And as you can see, the first patient was enrolled in September 2019. And a total of 1,100 patients are to be accrued to step 1 to allow for a 5% dropout, so as to allow 950 patients for the first randomization. And as of now, 955 patients have been enrolled to step 1, of whom 873 have undergone first randomization. 30 patients have made it to the second randomization at this point. Here we see the accrual trends since September 2019. The projection was we would see 13 to 14 patients enrolled on a monthly basis, but as you can see, the accrual has exceeded our expectations. Here's a list of the top 12 enrolling sites with more than 15 patients enrolled, starting with City of Hope with a whopping 90 patients, followed by WashU at St. Louis with 44 and Medical College of Wisconsin at 43. And here are some of the recent updates over the last 6 months. We are excited that our Canadian colleagues have joined the trial. The trial was activated in Canada in April, and as of now, 2 sites have been activated. There was a quality of life amendment, which was approved in Revision 5 in May, and we tackled 2 important issues in Revision 6. One was the issue of managing cytopenias as toxicity of the maintenance therapy in patients with Duffy null phenotype, And the second was a need to obtain baseline archival sample for test ID or clonality ID from the time of diagnosis of myeloma to be able to do MRD testing later on in the trial. We also have a revision 7 in the works that pertains to the use of HydroShift 2x4 daratumab assay to evaluate the biochemical responses more accurately. So we know that individuals of certain minority ethnicities can present with persistently low neutrophils without significantly increased risk of infection. And this condition has been referred to as benign ethnic neutropenia, which is actually correlated with homozygosity for a SNP in the promoter region of the DARC gene, Duffy antigen receptor for chemokines. And that results in Duffy null red cell phenotype. So the Duffy antigen acts as a cytokine sink that binds to the inflammatory cytokines. So Duffy null individuals have fewer neutrophils in the periphery, but they have normal marrow cellularity and maturation, and they respond robustly to infection. So red cell phenotyping is actually the best way to identify benign ethnic neutropenia rather than race or ethnicity. And current evidence indicates that the risk of febrile neutropenia due to myelosuppressive chemotherapy is not increased with Duffy null phenotype. So having a rigid high ANC reference range that does not reflect Duffy null phenotype can limit the access of certain patient populations to cancer clinical trials. And evidence supports that careful blood count monitoring and prophylactic use of growth factors would provide sufficient safety for Duffy null individuals in clinical trials. And we can achieve that through explicit changes in eligibility and dose modification criteria. So we have used an ANC of more than 1,000 as a starting point for maintenance in all patients. But for Duffy null individuals, we will aim to maintain an ANC of more than 750 and modify the Len and DARA dosing accordingly, as shown in the tables here. Another issue that we've encountered is that patients who we did not receive a baseline archival sample or commercial B-cell clonality ID on. And so these patients will not be able to undergo second randomization since we won't know whether they are MRD negative or not. And so we saw that in 24% of the patients who had the first randomization, they did not have a baseline archival sample submitted. In addition to that, we have seen that 18% of the samples that were received failed quality control or were found to be polyclonal. So we have amended the protocol to allow only those patients who have a baseline sample available or commercial B-cell clonality ID available to be eligible for the trial. And that was done in revision 6, which went into effect in early September. And lastly, daratumab, as we know, is an IgG kappa monoclonal antibody, which can co-migrate with the disease-related M protein and can lead to false positive results on immunofixation assays in patients with IgG kappa myeloma. So HydroShift assay, which is now FDA approved, uses an anti-daratumab antibody to shift the migration of daratumab anti-daratumab complexes towards the alpha globulin fraction immunofixation, and therefore can overcome the interference by daratumab. So HydroShift assay essentially can distinguish daratumab from disease-related IgG kappa M protein on immunofixation and allow assessment of M protein without Dara interference, as you can see in the top panel on the right-hand side of the slide. In other cases, it can show the immunofixation is actually negative after removing daratumab from the equation, as shown in the bottom panel. So we are expecting the revision 7 to be approved soon, which amended the protocol to include HydroShift assay to be done for patients with IgG kappa myeloma in very good partial response. And with that, I will stop, and I'm happy to take any questions.
Again, I think it's important to emphasize the importance of getting a pretreatment sample. Approximately 1/3 of the patients may not be evaluable for this trial, and because of that, there's going to be a statistical change in the N, initially 1,100, and now they're talking about going up to 1,400. So for those of you who are feeling like the trial is almost over and why bother putting your patients on it, we still going to need approximately 400 more patients. So a little bit disappointing. They are going to try to go back and recoup some of these samples, but please really work hard to get the pretreatment sample for MRD analysis in. Again, any questions or comments? Otherwise, we'll keep moving. The next trial is the Alliance 05 101801 Can you move that forward? These are all in a continuous loop for the slides, so just keep moving them. Or do I have to? There we go. I'll just do it myself. As everybody knows, this was the auto transplant trial of transplant plus or minus ibrutinib for patients with ABC subtype. Initially started with a nanostring analysis, and that turned out to be a major problem with only a small minority of patients actually eligible for the trial. The trial was halted, restarted using immunocytochemistry only, the Hans algorithm, and the trial was resumed. And as you can see, approximately 108 total patients were pre-registered afterwards, and 57 patients accrued after the initial 35 or so patients. Because accruals were decreasing, they redid the statistics, making it a little bit less rigorous, and the N changed from 300 down to 160. So 75 more patients were needed. Again, accrual lagged. So there was an interim analysis performed after 40 randomized patients completed 2 years of trial. This was the end of March. This was completed, the DSMB analysis completed in September. And I can tell you now that this passed the futility analysis, so again, potentially a positive trial. So the trial was recommended by the DSMB to proceed. However, there have been 0 accruals in the last 5 months. And with a consultation of the Alliance senior leadership group, it was decided that the time for this trial has passed, with many patients going on to CAR T therapy now as second line, especially these high-risk ABC subtype patients. And so the trial was closed last week. They are going to do a formal analysis of the approximately 85 patients that were actually enrolled on the trial. So we might ultimately get a result that suggests that ibrutinib should be used in these patients. Just to inform centers that there is an interest in looking at all patients that were screened and potentially transplant. Stay tuned for that, and hopefully that we'll get more information out of this than just the 85 patients. So a little bit disappointing because ultimately it could be that the ABC subtype with ibrutinib maintenance gives a better result than even CAR Ts for these patient population. Hopefully we'll have some information on that and then can move forward. So a big disappointment, but again, with no accruals in 5 months, this trial will never get done. So let's just move on then. And Brian Till should be on the phone. He's going to talk about a trial that is moving along very nicely, the ECOG A4151, which is the mantle cell trial in first complete remission. Brian, I'll do your slides.
Thanks, Dr. Stiff. You can go to the next one. My disclosures. And the next one. So I'll try to go quickly here through the background. So auto transplant is considered by many to be a standard care for younger patients, but it is somewhat controversial. It really hasn't really definitively shown an overall survival benefit, but it's still considered standard care. And so most people. Next slide, please. Maintenance therapy, which also. Next slide, please.
Yeah, it's not moving now. So try. Guys, the slides are not moving anymore. Where's my help? They lost signal.
I could also share my screen if that helps.
Why don't you go ahead? Oh, you got it? Oh.
You can also talk while you're doing that if you want.
I love these hybrid meetings. Brian, why don't you go share your screen, see if we can get these going.
Is it going? Can you see my screen?
Nope. Okay, great. We're good.
Okay. Yeah, so anyway, so maintenance therapy is also considered a reasonable standard thing to do after well, it's really a standard of care, I think, after transplant, with the French study showing a overall and progression-free survival benefit with 3 years of rituximab therapy after an auto transplant. In the non-transplant setting, it's also a reasonable thing to do. There's the European study that showed a overall survival benefit after R-CHOP only in elderly patients or in older patients. It's a little bit less clear with bendamustine and rituximab, with their German randomized study not showing a benefit. However, it was a relatively small study. There was this recent paper that came out just recently in JCO. There was a large retrospective study that did show both time to next treatment and overall survival benefits for maintenance rituximab after both R-CHOP or bendamustine rituximab. So it seems, I think, a reasonable thing to do for maintenance in the non-transplant setting as well. MRD has been shown by several groups to predict outcomes after induction therapy. So MRD negative patients do better than the MRD positive patients, not surprisingly. So with putting all that together, the assay we're using is adaptive clonoSEQ assay that uses the rearranged IgH B cell receptor genes in B cells to identify low levels of disease. It can pick up about 1 in a million tests. There's 2 steps. You first have to send in the tumor biopsy FFPE tissue from diagnosis to identify the clone, and then later on you send in a peripheral blood MRD test. So the idea here for the study is that we're trying to use MRD as a kind of a risk stratification after induction to see if we can spare auto transplant in some patients with mantle cell lymphoma who get deep remissions with induction, and we're allowing any induction to kind of try to mimic a real world scenario. So patients get any induction therapy, then they can register at that, anywhere along the way up until during or after induction. They get their tissue from diagnosis sent off to adaptive to identify the clone. If there's a clonal marker present, everybody gets restaged with a PET scan and bone marrow biopsy. And then the population of interest is here. If they have a negative MRD negative complete remission, they get randomized. So then they get randomized to a transplant or no transplant. And both groups get 3 years of rituximab maintenance based on the data I shared. Everybody else who gets a partial response or doesn't get a good response or gets MRD positive, or they don't have it's indeterminate because their marker didn't work, the assay wasn't clear, they just stay on study and get the standard kind of considered standard of care auto transplant and rituximab, but we still kind of follow them in separate arms. So here's the update on accrual. It's, as Dr. Stiff said, it's moving along pretty well. There have been 500, well, the target accrual initially was 689 patients. That was to get 434 eligible randomized patients. And so we've passed the total amount of total, we're getting close to the 434. I don't know exactly what that is. Maybe in the 400 range of the randomized patients. Close to 80% of them are MRD negative. So that's just most of the patients are getting randomized. ECOG is leading the way. SWOG is kind of in third place here. Some of the strongest SWOG institutions are City of Hope in Kansas, Utah, Seattle, and Alabama, Birmingham. And then the main update, I think, as I mentioned last time, is that unfortunately, we've had a fair number of patients who have refused their assigned treatment arm. And those are mostly patients who got assigned to transplant, who were secretly hoping for the non-transplant arm, and so backed out when they got the transplant. And so that kind of screws up the statistics for everybody, unfortunately. So I think it's close to 10 or 15% of the patients in that arm. So it's enough of a skew that we went back and talked to the statisticians and decided it was worth trying to increase the number, the total accrual goal for the study. And based on, you would think you could just intuitively add another 15% or something, but it doesn't work that way statistically. You have to actually add like 40%. So it's going to actually be like 200 more patients that need to be added. So we're kind of waiting to hear, and there's two parts of it. There's the CTEP just approval of the change, but what really is the kind of the crux of the matter is the funding, the BIQ SSP funding that pays for the assay. So there's this integral adaptive clonoSEQ assay that's not cheap. So we're waiting to, it's in the process to kind of ask for approval for additional funding to cover the additional, stay tuned for that. Hopefully that will go through before there's any kind of delay on, we're kind of hoping actually we don't hit the accrual goal too quickly, or else it may lead to a kind of a delay in accrual, which nobody really wants. Otherwise, it's just kind of my standard caveats here that I won't really go through. Just you can skip some doses for COVID-19, which I don't necessarily recommend doing, but you can and make it up at the end. Let the white count recover before you send the MRD test. And the patients who refuse their assigned treatment do stay on the study. We just keep tracking them, and later we'll do as treated analysis. And yeah, so any questions?
Get any questions? Again, the only thing that we can do, hopefully, is counsel the patients before they're randomized. And if they're really not willing to go to transplant, if randomized to transplant, then not enrolling them is actually the better option than enrolling them and then having them drop out. So any other questions or comments? Thank you, Brian. Do we have an estimated timeline for this trial to be completely enrolled?
Well, it depends if we get the approval for the 200 patients or not. So that's gonna, if we don't get it, then it'll be accrued pretty soon, maybe by the end of the year, even possibly. If we do get the 200 patients, that's going to add a couple of years, obviously. Okay.
It's interesting that we don't have as much trouble getting the pre-treatment specimens as we do for the myeloma study. So I don't know what the issues are unique to the myeloma trial. All right, let's keep moving. Thank you, Brian. The next is Dr. Hagan is going to talk about a pending trial for amyloidosis, transplant versus non-transplant.
I guess I'll sit. Okay, thanks. So thanks everybody. This is a study that's been in development for about a year now and is kind of close to the finish line with NIH approval recently. So in its heart, this is a study looking at the optimal consolidation in amyloid patients, particularly with Dara-VCD now recently FDA approved and the common induction regimen. This is a pretty actually ripe time to do the study. This has been a really collaborative effort with ECOG Alliance, the BMT CTN, the CCTG, A lot of, I think, important people have had a lot of input on this study design. So we'll kind of go through things here. So the study schema is in a couple slides here, but the endpoint on this trial is a little bit unique. And we're looking at something called the modified PFS, or modified major organ deterioration progression-free survival. So that's a mouthful. But essentially what this is looking at is a combination of important endpoints in amyloid, which includes hematological progression, obviously overall survival, but also renal and cardiac progression. And so this is a newer endpoint that was really fastened by the Andromeda study, but really does capture, I think, the important clinical endpoint in these patients, and also makes a rare disease where patients do really well over long periods of time actually doable in terms of doing this study. So that's the primary endpoint. We're looking at a lot of obviously very important secondary endpoints here, quality of life with some PROs built in at various time points, obviously overall survival, individual organ progression, and some nice studies looking at MRD both in the bone marrow as well as in the peripheral blood by mass spec. And then kind of some of our standard toxicity endpoints. So here's the treatment schema with my Microsoft Paint high school diagram here on the right. But basically, all patients are going to get standard uniform induction, which is DARA-VCD. And there was a lot of discussion about numbers of cycles. But after feedback from the NIH with the initial review, we've settled it in on 3 cycles. So they'll get 3 cycles of DARA-VCD. At that point, if they're still transplant eligible, they would be randomized 1-to-1 to either do 3 additional cycles of DARA-VCD, kind of as for the Andromeda protocol, or to go to high-dose chemotherapy and autologous stem cell transplant. And then after their consolidation randomization, all patients will receive 18 months of daratumumab maintenance, again, modeled after the Andromeda protocol. If patients are not deemed transplant eligible at that second registration step, they'll be removed from the trial, but they'll be followed on a registration basis. And then we are not mandating stem cell collection, but we're highly encouraging it. And there's some time points built in the trial to give enough time for patients to collect, particularly if they're not randomized to transplant. I would hope they'd collect their stem cells if they're randomized to transplant. So here's some of the eligibility. So this is the initial eligibility at diagnosis. Patients have to be eligible to receive a transplant. They have to be age less than 70. They have to have proven amyloid. They have to have measurable disease. And actually, we recently, the serum difference in the free light chain, we actually recently dropped that to be greater than 2. So that's not updated on this slide to enhance eligibility here. And there's some new data that would support that. Performance status, and then transplant eligibility. So blood pressure, cardiac markers, then some standard organ criteria, including, importantly, GFR, creatinine clearance. And then after they get their 3 cycles of induction, again, they have to be eligible for transplant. This is essentially all the same criteria, but in addition, they have to achieve at least a partial response to that induction, because we wouldn't want those patients with stable disease being randomized to the same treatment. So here's our methodology and our statistics. Again, our primary endpoint here is the modified PFS. We've estimated the non-transplant arm that to be 31 months. That's based on estimates from the Andromeda study. This is a 2-arm trial. Ultimately, we'll have 143 participants on each arm. We're looking at accruing about 29 patients per arm over 5 years with 3 years of follow-up. So that corresponds to a mod PFS increase of 31 up to 50 months in the transplant arm. The final analysis, again, will be done after 192 events or 4 years after the last patient was accrued. So we're anticipating about 15% drop-off in patients who will be registered but ineligible. Again, this is going to be mostly due to those few patients that won't achieve a response, and then those who won't be transplant eligible after their induction, their 3 cycles of induction. So this is actually, there is a typo here. It's 169 that will need to be registered to each arm to give us ultimately 143 eligible patients to undergo randomization. There's stratification factors, importantly Mayo staging, which is cardiac markers, hematological response, and then translocation 1114 in the bone marrow. There's some very important quality of life measurements that we're going to be looking at. Again, it may very well be that this is a negative study with equal outcomes in both patients because they're both very good treatments. But we may see very different short-term toxicities from transplant versus long-term toxicities from ongoing Velcade use in the non-transplant arm, for example. And then we have some really nice translational studies actually that are built in and supported by Janssen. This is going to include next-gen flow MRD on the bone marrows, as well as mass spec from peripheral blood, actually every 3 months, but most importantly after induction consolidation, and then 6 and 12 months after, and then 12 months after consolidation. So this is kind of where we are on the timeline. This took a while to kind of get through the NIH, but now we have approval, so things are kind of on rapid fire. We actually have our PRC meeting next week. So hopefully with a lot of support, we can kind of keep things moving and stick to these timelines, but we're a little bit of a faster pace here than we'd like to be, but so far actually things are going nicely. From a transplant community perspective, I think one of the issues here is going to be referrals in from surrounding centers. So we're really going to need to work closely with the community enrolling sites. But then also, the patients will need to go on to maintenance daratumumab after their transplant, which typically is not standard, although some places are doing that. So, that's one logistical hurdle that we'll have to kind of keep an eye on and work closely again between the transplant centers and potentially referring centers. So that's all I had formally, but more than willing to answer any questions if anybody has any.
We just heard about the mantle cell, 10 to 15% of patients randomized to transplant, not willing to undergo transplant. Have you considered that in your numbers?
Yeah, so, we had talked a lot about eligibility and then ultimately drop off over time. And in amyloid trials, it's kind of all over the place. It's as low as 5%, upwards of 30% on certain trials. So yeah, that is taken into consideration. Certainly, I think we've learned some lessons from the mantle cell trial. So, I think, and historically, transplant versus no transplant studies do have that. There's always going to be a challenge of that. So we feel 15% is reasonable, but it's something we're going to have to watch closely for sure.
Again, I think the other thing about this trial, however, is that patients will be enrolled at the time of diagnosis versus the mantle cell, where many of them are just coming into it because they've completed therapy and are eligible for that. So it's I think many of us feel that this is an important and very timely study because of the Andromeda trial showing that Dara-VCD is an effective regimen for these patients. The question is, can we put people into longer and deeper remissions with the addition of transplant, or do we have to do transplant? As many of you know, transplant is not commonly done for amyloid in Europe. It's done more commonly here in the United States. And many of us over many years never gave these patients induction therapy at all prior to transplant and still saw 50% long-term remissions with transplant. So there is a transplant efficacy, and the question is, can we really knock these out of the park by adding transplant to induction therapy, or do we have to, especially with the possibility of maintenance therapy for those that are not randomized to transplant? And again, as Patrick alluded to, stem cell collection is not mandated prior to randomization, so that a patient is randomized not to transplant. They do not have to undergo stem cell collection, but certainly they can do it. It's not an ineligibility to do that, and it won't delay their therapy, so potentially in second remission or second line therapy. How often is amyloid transplants being done in second line therapy now? Do you know, in Europe? And
yeah, it's really rare. So again, the NIH did ask us to follow patients who were randomized to the non-transplant arm that would go on to receive a transplant. So we are going to track that, but it's a pretty rare event. And the way the protocol is designed now is after their 3 cycles of induction, patients have 6 weeks to complete their registration step 2, and then 8 weeks after that to start their assigned consolidation. So obviously, if you're getting a transplant, you're going to need that time to get worked up and collect, but that also gives adequate time for the non-transplant arm. But then patients, obviously, if they're ready and registered, they can move forward with their additional Dara-VCD. So.
Okay, so we hope to have this activated by the time the next meeting is coming by, and any questions or issues, feel free to contact Patrick. This committee overlapped with Lymphoma Committee, and the next presentation was supposed to be the E4211. I don't see Brian back here. It's after 11. So let's move actually, Dr. Kenkry is actually up next to talk about the ECOG-led chemotherapy versus transplant, salvage therapy for auto transplants for relapse refractory Hodgkin's lymphoma, a theme here today. You are ready to go. I see you. Please proceed.
Okay. Thank you for inviting me to speak about this today. So this is an update on this randomized study. And just to give some background, I think there's a slide before this. There, yeah. So as many of you know, frontline therapy for Hodgkin lymphoma can be curative in a majority of patients, but for those who are not cured, salvage therapy followed by high-dose chemo and auto transplant is the current standard for second-line therapy. And this can often offer durable remission and even potentially cure for a majority of patients. We do know that, at least as of data we have from current studies, prior studies, that this consolidative transplant does improve the likelihood of a longer progression-free survival and possibly overall survival benefit than compared to when salvage chemotherapy is given alone. So as many of you know, over the last couple of years, there's been promising data that is phase 2 data where checkpoint inhibitor has been added to this salvage chemotherapy in the second line, and then patients go on to transplant. And it does appear that based on phase 2 data, just comparing to phase 2 chemo-only studies, that this might actually benefit the overall success of this strategy by adding that checkpoint inhibitor to the salvage chemotherapy. But we have not technically had a head-to-head comparison of chemotherapy versus chemotherapy plus checkpoint inhibitor. And so this phase 3 study is designed to ask that question, if adding checkpoint inhibitor to salvage chemotherapy can actually ultimately increase the efficacy of the transplant and eventual cure rate. So this is the schema of the study, and I'll walk you through this. The patients who will be eligible are those who are either primary refractory or in first relapse after their frontline therapy. They would be randomized to either getting chemotherapy versus pembrolizumab plus chemotherapy. And below there, you can see that there are 3 chemotherapy backbone options, ICE, GBD, and bendamustine. And for each patient, the investigator would determine prior to randomization which chemotherapy backbone they would like to be using. And then depending on whether the patient gets randomized to arm A or B, they would either get that chemotherapy backbone or that chemotherapy backbone plus pembrolizumab, respectively. So patients would get 2 cycles of whatever salvage regimen they ultimately are assigned to, and then have a PET scan for evaluation. If they are in a complete remission or a partial remission, and we went back and forth a lot on this, but ultimately realizing that we could realistically probably only get PET scans and not dedicated CTs, we are defining a partial remission as just by the nuclear response, the metabolic response, not by CT criteria. But if patients are in a CR or PR after those 2 cycles, they would go on to transplant. In the setting of a PR, the investigator can choose to try to give another regimen on the same arm of the study if they would like to try to deepen the response. So in other words, if a patient were on arm A of the study receiving ICE and after 2 cycles achieved a PR, the investigator could either take them on to transplant or decide to give them either GVD or bendamustine to try to deepen the response. But we would like to encourage that ultimately patients in a PR do go on to transplant, because we would like to see how those patients do, because we do believe that patients in PR can still have success with transplant and ultimately convert to CR. However, if a patient after 2 cycles has either stable disease or progressive disease, they would come off study, count as an event, and the treatment would be by investigator's choice. So patients in a CR and PR go on to transplant. And then on the right of the screen there are two options for possible consolidation. So per Athera criteria, we will allow for BV maintenance. Oh, not done with that slide, sorry. So we will allow for BV maintenance per Athera criteria, and even pediatric patients would also be allowed to get this. We would like that intent, though, declared prior to randomization. So the investigator would choose whether they would like to give this patient BV maintenance or not if they meet Athera criteria. And then the second option is also to give post-transplant radiation for a patient who goes into transplant in a PR. And this was also heavily debated. A lot of investigators on the working committee felt we should not give radiation. Many felt that we should be allowing radiation for the PR patients pre-transplant. And so in the end, we decided to allow the investigator to, again, declare the intent prior to randomization, so that if that patient goes into transplant in a PR, you are deciding whether or not you would want to give the post-transplant radiation therapy. Ultimately, the patients who are in a CR after transplant, they would kind of continue to be monitored. If they're still in a PR after transplant, they would count as an event. I will just kind of in a moment be ready for the next slide, but what I will point out is that we are going to stratify by what frontline therapy the patient received, as you can see the options there, by the age group, basically pediatric versus adult, essentially, and then the intent to use BV maintenance and the intent to use post-transplant radiation. The accrual goal is for 312 patients. So our primary endpoint is to look for an improvement in the 2-year event-free survival. We are assuming, based on prior studies, that the chemotherapy alone arm has a 2-year EFS of about 65%. And we predict that we can improve upon that by about 15% in the checkpoint inhibitor chemo arm. And so events to come to be counted would be if a patient has either stable disease or progressive disease after the salvage regimen, so that, in other words, they don't achieve a PR or CR. If they have failure to achieve a CR post-transplant, so if they go in to transplant in a PR but don't convert to a CR ultimately with transplant, they would count as an event and come off study. Or if at any point they have progression of disease or death. Secondary endpoints that we are looking at is specifically the 2-year PFS in the transplanted population, the CR rate to salvage therapy, the CR rate post-transplant, and then what is that conversion rate of patients who go into transplant in a PR and then ultimately convert to a CR. So we have had a little bit of back and forth with CTEP, but we did submit what is likely to be close to the final protocol last month, and we are awaiting their comments to that, but that was after sort of initial revisions to their initial review. So at this point, we are still anticipating protocol activation by later this calendar year. I'm happy to take any questions or comments.
So is the current ECOG relapse lymphoma Hodgkin's trial fully accrued?
Are you referring to the checkpoint BV
Yeah.
Catherine study?
Yes.
Or?
Yes.
Yeah, I believe that there are still maybe a couple of arms of that might be accruing. I guess we have our ECOG meeting next week, so I'll probably get an update. But I do believe that there was still a little bit of accrual left on that study.
So it seems as though, at least at our center, that the number of relapse Hodgkin's patients is dwindling. Is that a concern for this rather large trial?
In terms of which population specifically?
The relapse. In other words, there are fewer people relapsing after upfront therapy.
Yeah, I mean, I think that we still have those. Are you feeling that way because the the A squared BD regimen has been kind of
Yes.
more successful, or?
Yes.
Yeah, I mean, I feel like I'm still seeing relapse. I mean, maybe further down the line, like after a year or two, but I don't think that I haven't specifically been concerned about that. I guess obviously we'll have to see, and we will be, stratifying as well by what regimen is given.
Okay, anybody else? All right, Brian, you're up. Next, we're going to hear about the randomized trial of consolidation therapy after commercial CAR T therapy. Brian Hess is going to present.
Great, thanks. Are people presenting kind of from here or go up here? Okay. Dr. O'Brien, is this your second time seeing this presentation today? Okay, I'm sorry. I'm so sorry for you, but all right, here we go. Well, you love the misery. This is S2114. We're really close to activation and really excited about it. This is a randomized phase 2 trial of consolidation therapy following CD19 CAR T for large B-cell lymphoma and follicular lymphoma grade 3B. So this study involves the most common lymphoma diagnosis that we see in our clinics. And overall, the majority of these patients are cured. We know this with frontline therapy. And for the patients that aren't cured, for a very long time, the prognosis for these patients was incredibly poor, even if they were candidates for salvage chemotherapy and auto transplant. And this was especially true in patients that were refractory to chemotherapy or that had relapsed after multiple lines of therapy, as was shown in SCHOLAR-1, where these patients have very poor prognoses. And then came 3 different CD19 CAR T trials that were phase 2 in the third line setting or greater, and basically showed improvement in outcomes in basically every metric compared to these historical studies like SCHOLAR-1. But you can see from ZUMA-1, here that the PFS curve still has significant drop off with it leveling off in 6 to 12 months. So CD19 CAR T, great breakthrough in this setting, but unfortunately the majority of patients are relapsing. And that's consistent with the other landmark studies that led to approval in this setting as well. So then they looked at CD19 CAR T as second line therapy. I'll just go through this slide a little bit quicker because I don't think I have as much time, but they looked at patients who are in the second line setting who are transplant candidates, CAR T versus salvage chemotherapy and auto transplant. Looking at the ZUMA-7 study here as an example, you can see a significant improvement over the standard of care, but still the 24-month PFS or EFS is 41%. They also looked at second line CAR T and non-transplant candidates in the phase 2 pilot study with liso-cel. Again, very promising outcomes, durability of response, but the majority of patients are relapsing. So altogether, all of these studies really help to define CD19 CAR T as the standard of care for nearly all patients with relapsed diffuse large B-cell lymphoma, whether it's in the third line setting or in the second line setting. So our question was, how can we identify patients who are high risk for relapse post CD19 CAR T? And we believe the answer to that is in the post CAR T setting with these day 30 PETs. There we go. So if we just make a summary of outcomes based on these day 30 responses, about 50% will have CR at day 30. The majority of these patients will have a durable response, with about 30% of patients progressing. About 20% of patients will have progressive disease and have very poor outcomes, and about a third of patients have partial remission or stable disease. Some of these patients do convert to CR and have a durable response, but the greater majority of these patients are relapsing. So this is the patient population that we identified as high risk for relapse after CD19 CAR T. And the reason that this question is so important to us is because we know that after patients progress after CD19 CAR T, they typically do incredibly poor. So if we can identify these patients that are high risk for relapse based on that day 30 PET, the next question is, are there consolidation therapies that we can give that are not only effective, but also safe, being that it's so close to CD19 CAR T? So Traditional therapies like cytotoxic chemotherapy, radiation therapy, checkpoint-based, Revlimid-based therapies really haven't shown a lot of promise in this setting. Even in patients that respond, they typically don't respond for very long. And so again, we were looking for more novel agents in this setting that would be effective. Polatuzumab vedotin is one agent that we identified, antibody drug conjugate to CD79B on the surface of lymphoma cells, is internalized into the cell, releases its cytotoxic payload. Promising in the relapse setting with bendamustine and Rituxan compared to bendamustine and Rituxan alone. Also a retrospective looking at polatuzumab with Rituxan or Rituxan and bendamustine in patients specifically that relapse after CAR-T was promising. So we won't be using polatuzumab with cytotoxic chemo in this study because of the toxicity implications in patients receiving CAR-T so recent, as well as the potential unwanted effects that these cytotoxic chemo agents like bendamustine could have on circulating CAR-T cells. Bispecifics are agents that have been shown to be very effective in lymphoma, both in indolent and aggressive non-Hodgkin lymphoma. BiTEs work by directing T cells to lymphoma cells by binding CD3 on the surface of T cells and the tumor antigen on lymphoma cells. Mosunetuzumab binds CD20. It was looked at in an aggressive non-Hodgkin lymphoma population, heavily pretreated, including patients that received prior CAR-T. And it was given as a step-up dosing in this study to help mitigate toxicity, including cytokine release, which is commonly seen with BiTEs. Overall, for this study, good overall response rates and CR rates, considering how heavily pretreated these patients were, and that was similar in patients that received prior CAR-T. Again, cytokine release is seen with bispecifics, only seen in a quarter of these patients. In the majority, it was grade 1. They also looked at the combination of mosun and pola, which they presented at ASH this past year. You can see really, really promising overall response rates, 2/3 of patients, with nearly half of patients having a CR, even in patients that received prior CAR-T. And once again, the CRS incidence is low, in the majority having grade 1, which constitutes just having a fever. So our hypothesis was using mosun alone, pola alone, or the combination as consolidation in these patients with stable disease or PR after on day 30 PET will help to prevent a higher proportion of these patients from relapsing. So for this study, all patients will have to undergo step 1 registration prior to CAR-T. Patients can sign up for step 1 registration anytime from when they have local consent signed for CAR-T consent up until when LD chemo starts. I'll go through these inclusion criteria quickly just for the sake of time, but I think the most important point is that bridging is allowed, but they can't have pola or mosun, so no BR pola for any of these patients. And if you do have bridging, you have to have a PET repeated, whether it's radiation or systemic chemotherapy, and we've asked for the sponsor to cover this PET, and they've agreed. Polatuzumab previously is allowed, which we may see a lot more if and likely when it's approved in the frontline setting with RCHP, likely to be this spring. You can have CAR-T that's on study, so no non-FDA approved CAR-T cells, including FDA or products that are non-conforming or out of spec and given on a single patient IND or expanded access protocol. All patients will have a day 30 PET after CAR-T. This day 30 PET and the baseline PET will be uploaded to IROC, which is the Imaging Radiology Oncology Core, and they will give their central review. So if patients have a CR, they'll continue on observation on the study. If patients have progressive disease, then they will go off study but be followed for overall survival. And the important one, if patients have a central review of stable disease or PR, they'll be eligible for randomization to one of 4 arms, mosun, pola, the combination, or observation, and have 30 patients per arm. For the patients on observation, they will be eligible to cross over to the combination of mosun and pola if they progress within a year of randomization, and hopefully this helps prevent drop-off for the patients that are randomized to observation. So key inclusion, again, having stable disease or PR by that central review. We know that a lot of these patients can have cytopenias with CAR-T that can continue past day 30. So we're allowing patients to be randomized up to day 60. And then we're also, we're stratifying by stable disease versus PRs. We know these PR patients tend to do much better, as well as second line versus third line or greater CAR T receipt. Primary objective of this study, 1-year PFS, where each of these consolidation arms will be compared to observation alone. And we're estimating the observation PFS of 25% and looking to improve that to 50% for each of these consolidation arms. So real quick, each consolidation arm, time-limited therapy, 21-day cycles, Mosin given on step-up dosing with cycle 1, again, to help mitigate cytokine release and toxicity. Arm 2, 6 cycles of polatuzumab, and then arm 3, the same dosing for Mosin, and then Polo will be introduced on cycle 2. Secondary objectives, overall survival, CR conversion rate for all of these consolidation arms and control. We'll be paying close attention to toxicity because these agents are going to be given so close in proximity to CAR T. And then correlative objectives, like I said, all these PET scans, these baseline PETs and day 30 PETs are going to be uploaded to IROC. So we'll be able to look at total metabolic tumor volume, SUV max, some product of diameters at day 30, also look at the delta between baseline and day 30 and its association with CR conversion. Minimal residual disease is a really important aspect of this study. We'll be banking peripheral blood samples in order to prospectively look at this, not only in stable disease in PR patients, but also in CR patients. And so we haven't definitively identified which assay we're going to be using for minimal residual disease, but we are planning on evaluating circulating tumor DNA and peripheral blood for CAP-seq NGS panels. In other words, just evaluating peripheral blood for evidence of lymphoma. We know that MRD, a number of different assays of MRD have been shown to predict higher likelihood of relapse post-CAR T. Still a lot of granular data that we don't have in terms of these subgroups. Post-CAR T, stable disease PR, can we identify this third of patients with CR at day 30 that eventually progresses? Are there better time points than day 30 in terms of identifying minimal residual disease? Also, if you are MRD positive for these patients, does consolidation therapy actually improve your outcomes? Can it be used in conjunction with PET to improve the sensitivity and specificity? So answering all of these questions or some of these questions, hopefully, will help us to evaluate if an MRD adaptive study is possible in the future. In terms of schedule of response assessments and biomarker draws, including MRD and other correlatives, they're all going to be intertwined, but they will be based on day 30 PET response as well. So all patients will get a PET and biomarker draw at or prior to lymphodepleting chemotherapy, as well as day 30 post-CAR T. And then if you have progressive disease, that's the last time that you have either of these assessments. PR, stable disease, the next time is day 60 after randomization, hopefully catch these patients right before cycle 4, day 1. And then we'll also be looking at day 180 and day 360, 1 year after, this being the primary endpoint of the study. CR, these assessments are based on or relative to when the patient received CAR T. They've been working really hard on the PROs, thanks to Ajay and Geeta for doing that, and the patient advocates. These survey assessments will actually basically mirror what I showed on the previous slide in terms of when they're going to be done. They are presenting to the SWOG Executive Committee on Monday, so we're really excited to envelope these into the study. So about a third of patients will have a partial remission or stable disease, we believe, at that day 30 PET. We assume that about 10% will drop out after step 1 registration, so that we will need 396 patients, or we've estimated to need 396 patients in step 1 in order to randomize 120. So because we need 400 CAR T patients, we not only need all these SWOG sites to participate, but we need ECOG and Alliance and BMT-CTN absolutely to participate. We'd never get this study done. We've had a lot of great collaboration with them so far, so really optimistic that this continues and hope to activate next month. We're looking to register 17 patients per month once we have all these sites up and running, and then in order to randomize 5 patients per month after that, and look for a 24-month accrual in order to accrue 120 patients, or in order to randomize 120 patients to step 2. So really excited to be this close. Thanks for everybody that contributed in getting this close to activating this study. There's dozens of you out there, and happy to take any brief questions.
Thanks, Brian. Sometimes the devil is in the details. Mosin is probably going to be FDA approved the end of the year. Will that be an ineligibility if they've received it prior to their CAR T?
I think because these patients that are receiving Mosin are going to be receiving it farther down the line, and the greater majority of these patients are going to be receiving CAR T as second-line therapy after relapsing after R-CHOP or EPOC, be going into CAR T. So I really don't see an issue with that Mosin approval.
Okay, well, you're going to have to put something in there, I think, probably eventually. And the second thing is, and thinking about this trial and patients that we've recently seen, I was on service, and the 2 patients that came in 1 week, both of them had their PET scans at outside institutions. Are we going to be able to include those patients? Do we need to repeat the PET at our institution because we're doing the pre and the post at our institution? Or will we be able to grab those PET scans and have those as the baseline?
Personally, I don't allow those day 30 PETs to be done outside your.
I'm talking about the pre.
The pre. No, so absolutely. No, the pre is fine. We expect that a lot of those will be done outside. Both of those will be uploaded to IROC at the same time.
Okay.
So those, you should have plenty of time for the site to collect the site that's giving CAR T to collect those scans, those baseline scans, and have them so that they can submit them at the same time with that day 30 PET.
Okay. And they have to be done within a certain timeline of.
Yes, and so that PET has to be done within 60 days prior to LD chemo. The only caveat again is patients who have received bridging therapy will have to have that repeated.
Okay. Any other questions, comments, concerns? This is obviously a very important trial, the first of its kind, and I guess it's kind of the first of the foray of any cooperative group into the CAR T zone, if you will. Certainly, we're interested in other thoughts and other trial designs. So if somebody has anything, feel free to forward them or a concept to us. I was recently talking with Alliance, and they do not have any CAR T or CAR T-like trials going in any disease. And so we're definitely interested in getting into the space, if you will, in the cooperative groups. Let's move forward then. And next we're going to talk about MyeloMatch, and I'm going to do a brief introduction, and then Matt's going to talk about the Tier 3 trial that hopefully will eventually get going. So for some of you who don't know it yet, Harry Erba is going to present, hopefully not the same slides, but some of these slides on MyeloMatch, the whole concept. And obviously the goal is to improve the curability of AML and MDS. We once had a talk from one of the leukemia experts about 10 years ago, and he said it's unlikely that AML will ever be cured because there's so many different subtypes. When you've seen one case, you've seen one case, and to come up with targeted therapy for that individual patient, it's just not going to be possible. And obviously, we're getting closer to that. And the goal, obviously, of MyeloMatch is to improve the MRD negative rate, which is certainly most appropriate for bone marrow transplant patients, because we know that MRD positivity marks for an inferior prognosis. Transplant is part of Tier 3, and we'll go over this in a moment. Tier 1 are the induction, Tier 2 are consolidation, Tier 3 transplant, Tier 4 are quote unquote maintenance or other therapy beyond transplant. Transplant or consolidation therapy does not necessarily have just to be transplant. It can be other emerging therapies, as we just mentioned, including immunotherapies. So Tier 3 again is transplant, and we're going to look at studies that compare transplant potentially down the line to no transplant, or basically transplant versus transplant enhanced therapies in a randomized phase 2 fashion. So there's a steering committee for Tier 3. It's led by myself and Miguel Perales from the Alliance. We have a steering committee which consists of 2 members from each of the cooperative groups, and then a larger group that will be looking and doing the trials. Protocols to be led by members of each of the 4 cooperative groups, including the CCTG, with protocol leadership that includes members from each of the 4 groups. The BMT CTN will be invited to endorse these protocols, and if they do, a member of the BMT CTN will join the protocol leadership team as well. Anyone from each of the 4 groups can submit a proposal for a Tier 3 study, and we're ready, willing, and anxious to see these. But one of the major tenets will be that competing protocols will not be permitted in the myelomatch transplant zone. So the fundamental design of Tier 3 studies will be to develop treatments that will affect the outcome of allotransplants for AML and high-risk MDS. And at the present time, we don't envision a transplant versus no transplant design for these typically high-risk patients. Down the line, it might be transplant versus immunotherapy, but it's going to be all augmented therapies versus standard of care. These trials will be signal finding and will be run as phase 1/2 or randomized phase 2 trials. For example, realizing MRD positivity at transplants is adverse in a phase 2 randomized fashion. Do targeted agents, when given during and early after transplant, decrease the percentage of patients with MRD negative disease at day plus 100 post allograft? Those are kind of the design and the endpoints that we're going to be looking at. We're not going to be looking at long-term overall survival in these early trials. So the options for trial designs that we'll consider are preparative regimen studies of novel chemotherapy or radiotherapy agents, combinations of standard preparative regimens with targeted therapies to be added, early maintenance consolidation using targeted or non-targeted agents up to day 100, and finally immunotherapy trials initially as an adjunct potentially to transplant, but potentially later compared to standard transplant studies. So currently, we envision that Tier 3 will really try to focus on MRD positive disease at transplant or those with a targetable abnormality, which can be MRD positive or negative, or those with a high probability of relapse that have truly adverse prognostic factors that might be MRD negative. MRD for the first series of protocols will be measured using a flow-based assay, but molecular assays will be performed simultaneously and validated as to the utility to serve as an alternative, potentially better endpoint in later studies. The first Tier 3 trial is an all-comers, which you'll hear about in a moment, allograft trial that will investigate venetoclax during the preparative regimen and its early consolidation to begin after day plus 28 up to day 100. And finally, if this is a positive trial and why we're kind of excited about this, it could establish that venetoclax would be a comparative arm in subsequent trials of targeted agents. We don't want to do trials with transplant plus or minus targeted agent in which half the patients don't get anything. If we can establish venetoclax as potentially efficacious for all sorts of subgroups, then eliminating a treatment versus no treatment series of trials that are likely to be unpopular with patients in MDs could be avoided. The second trial to be considered is a similar trial design using an IDH2 inhibitor for those with IDH2 positive disease with a similar treatment strategy, endpoints, and measurements. However, while we intend to develop a full menu of targeted studies in the future, given that this first venetoclax trial will include patients with currently targetable abnormalities as well as those not targetable, we do not want to create a series of trials that will compete with it, leading to a series of trials that will accrue poorly. So we've gone deliberately a little bit slowly in developing second and subsequent trials because we want to get the venetoclax off the ground and accrued. So with that, I'll introduce Matt Wiedewald, who is going to talk about the Alliance-led trial of venetoclax. This has been presented to the MyeloMatch group 3 or 4 times. It's undergone a lot of revisions and re-revisions, and sometimes we even went back to a prior concept, but it's been very useful and allowed us, I think, to move forward with a trial that I think everybody's going to feel is the right thing to do. So Matt, I'll advance your slides.
All right, thank you, Patrick. So just, I think as we all know that the inefficacy of reduced intensity transplant for AML is pretty clear with high relapse rates post-transplant of 50 or 60%. in both the in the reduced intensity setting, and 18 to 24 month relapse-free survival of about 40 to 45%, and that's in both younger and older patients. And then also the inefficacy of allogeneic transplant for MRD positive disease. In the University of Washington experience, MRD positive disease at the time of transplant had similar terrible outcomes to patients who went in with active disease, compared there to the blue line, which were MRD negative patients, and they did comparatively very well. Similar findings in the reduced intensity setting, where MRD positive disease does quite poorly relative to MRD negative disease. Now, other data has suggested that myeloablation can overcome this to a certain degree, not seen so much in the University of Washington data, but in other studies. Next slide. So how can we improve this lack of poor efficacy compared to myeloablative transplant? Reduced intensity transplant will before conditioning, elimination of MRD, which is part of the MyeloMatch effort. Oh, we have a note that some people can't see the slides. Is that okay?
We can see him here. We can see him here. Oh, there.
Okay. In conditioning, enhanced conditioning with novel agents, either targeted or novel like venetoclax, and then after transplant with prophylactic treatments, maintenance, cellular therapies, immunotherapies, and potentially preemptive treatments for MRD. Rationale for venetoclax is it does have single agent activity in AML based on a single study, with CR/CRi rate of about 20% with anti-leukemic activity in 38% of patients. Very well tolerated, the major concern being cytopenias, which can be managed with holds and reductions. And then for transplant, there were grade 1 to 2 AAEs of diarrhea, nausea, and fatigue. It is orally bioavailable, which is favorable, and that venetoclax 400 milligrams a day has been shown to be well tolerated with reduced intensity conditioning, flu-Bu2 conditioning as maintenance in the Dana-Farber experience. And that venetoclax is predicted to improve MRD clearance and relapse-free survival by increasing the efficacy of conditioning and delaying relapse, and delayed relapse may increase the opportunity for graft versus leukemia effect. This was a report from a phase 1 study being conducted by Jacqueline Garcia at Dana-Farber, who's also co-chair on the study, where they, what was reported here was simply combination of venetoclax with flu-Bu2 conditioning, and this was very well tolerated. A small sample set, there was no evidence of delayed engraftment or unusual post-transplant toxicities with this approach. I believe MRD clearance rates were about 50% post-transplant in a very high-risk patient population where the majority were actually P53 mutant. It also included both AML and MDS. Next slide. So the study design for this study is a randomized double-blind placebo-controlled phase 2 study of venetoclax with reduced intensity conditioning followed by transplant, then venetoclax maintenance in adults with AML and first complete remission. It's a proposed alliance-led intergroup study, and it has been endorsed by BMT-CTN. The rationale is that to have it blinded and placebo-controlled is more likely to keep patients on study and prevent alternative therapies. And because of after presentation at BMT-CTN and the last MyeloMatch chairs meeting, we decided to add a cohort to allow alternate donors to expand enrollment opportunities for historically underrepresented racial and ethnic groups on clinical trials. The hypothesis is that venetoclax with reduced intensity conditioning followed by maintenance venetoclax after allo, that should be modified. That's an old slide. It's basically the addition of venetoclax to reduced intensity conditioning, not with maintenance right afterwards will improve day 100 event-free survival by 20% relative to placebo, estimated from 60 to 80%, with an event defined as MRD persistence, MRD relapse, morphologic relapse or death, and MRD here is defined as greater than or equal to 0.1% by flow cytometry. This is the design for cohort 1. Eligibility, adults 40 to 75 with AML and CR1 with a match-related or match-unrelated donor enrolled in the MyeloMatch screening protocol at diagnosis. The conditioning regimens, conditioning A is venetoclax. A and B have the same base conditioning. So venetoclax, 2 options, venetoclax or placebo with fludarabine and busulfan, flu-bu2, or with fludarabine and melphalan 140. This was thought to give options for have a intensive conditioning option of melphalan 140 and a significantly less intense option of fludarabine and busulfan 2. The venetoclax is given through day -2 with kind of standard conditioning, followed by day 0 transplant. And the primary endpoint occurs at day +100 with its day +100 event-free survival, again with MRD persistence, MRD relapse, frank relapse, or death being the events. For patients without an event, they can continue on to maintenance therapy, and that's a second exploratory randomization to try to start to evaluate the impact of maintenance with venetoclax or placebo in patients who continue to be event-free. Both randomizations are stratified by MRD conditioning regimen, stem cell source, and ELN risk, and GVHD prophylaxis currently is tacrolimus and methotrexate, pending the CTN 1703 results. Cohort 2 is very similar. It's all adults age 18 to 75 with AML and CR1, mismatched unrelated donor or haploidentical donor. And this is a haploidentical approach and post-transplant Cytoxan approach in terms of GVHD prophylaxis with mycophenolate and tacrolimus. The first randomization, again, same stratification as cohort 1. The conditioning regimens we settled on were venetoclax or placebo with melphalan 70, fludarabine, and TBI 200, or melphalan 100, fludarabine, and TBI 200 to allow 2 different intensity options for treating physicians. Other than that, the cohort, which will be analyzed separately, has much of the same design. Major objectives is primary objective is the conditioning question, which is day 100 event-free survival. Secondary include a conditioning question, which is day +30 event-free survival in the MRD positive only patients, looking to see if venetoclax with conditioning is able to increase the early clearance rate of MRD. The regimen as a whole, which is event-free survival at 12 months, and the maintenance question is 12-month event-free survival from second randomizations. And then, of course, tolerability of venetoclax with both of the all 3 of the conditioning regimens. Key eligibility, we can skip this because I kind of did it already. The statistics, the primary endpoint will be analyzed separately for cohort 1 and cohort 2. Again, event-free survival at day 100, comparing estimates of 60% with placebo versus 80% as the alternate with venetoclax. So we'll require 64 evaluable patients. Oops, you can go back one. 64 evaluable patients per arm, or 128 per cohort, and up to 140 to allow for cancellations and ineligibility. And then we have for key secondary endpoints, we're requiring 35 MRD patients per conditioning arm to optimally assess the MRD clearance rates and the event-free survival. As far as suitability for MyeloMatch, we have the phase 1 data. It's an attractive combination, and we know this has single agent activity, and it is predicted to enhance conditioning and be tolerable. It will also potentially contribute to future targeted therapies, as this could be potentially given in combination with other targeted therapies such as FLT3 inhibitors, IDH inhibitors, what you like, and be a comparator arm, as Patrick highlighted. So this was presented at BMT-CTN and has got BMT-CTN endorsement, and Dr. Nelly Bajayanan is the BMT-CTN representative and has recently presented this again at BMT-CTN, and it met with a favorable response. So we're trying to move the concept forward now. We've completely amended it with cohort 2, and that's in review by the MyeloMatch transplant chairs.
I think we have time for one quick question or a comment. If not,
how long is the maintenance?
the maintenance goes up to day 100, from day 28 to day 100. And then,
I mean, when the venetoclax starts on day 100, how long does it go?
The maintenance goes for till 12 months.
okay, last but not least, another transplant versus no transplant trial, T-cell lymphoma. Mark Hoffman is going to present from Kansas.
Thanks everyone for this. So this is a randomized proposal of the role of autotransplant in PTCL in CR1. You may not remember this, but everybody was asking for this study for several years. So be careful what you wish for, but here it is. So this is, I'm just going to go through a couple of studies that indicate what we do know. So this is the prospective data from the Nordic study. It's important to understand when you look at these curves that these are not landmarked for transplant. These patients were enrolled at the time of diagnosis. And so this includes patients with primary refractory disease, of whom there are about 20%. And then patients all underwent transplant if they had a CR or PR to CHOEP induction. These are the curves. This is PFS. This is OS. As predicted, you would expect that the ALK negative ALCL patients did better than the other histologies. Among the other histologies, there's no significant findings. This was a recently published retrospective data set from the Netherlands. And this is looking at, they did a number of different analyses, but if you focus on analysis C, which is basically looking at auto versus not in patients who achieved a CR, and these are landmark curves. So this is different from the curves that you saw previously. These are patients who are already in complete remission, and we're looking at whether they were transplanted or not. And you can see that there is an overall survival advantage in these retrospective series. This has never been evaluated in a prospective randomized fashion for the role of transplant in patients who were in complete remission. So this is the proposal. We have gone around a variety of different times, but here we go. So it is a newly diagnosed PTCL study. It includes all of these following histologies. There had been some argument about histologies, but these are the ones that landed there. You have some type of induction therapy. It has to be anthracycline based, but we acknowledge that these patients will largely be induced outside of our sites. And then patients are enrolled at their end of treatment PET-CT. And patients that have a CR will be randomized either to transplant or no transplant. And that will be stratified by ALCL versus other histology, and then by etoposide versus non-etoposide containing induction. Those patients who have a PR, stable disease, or disease progression will be off study and managed per protocol. We needed 380 patients in order to have an OS event outcome. I'll go into the statistics in a slide or two later, but that's going to demand that all of you want to participate. So every cooperative group has to actively engage and want to put people on this study for it to work, because we're going to need that many people to actually get this to accrue. So these were a couple of things that have been contentious that I just wanted to bring up as points of interest. One was when to enroll. Do we enroll at diagnosis, or do we enroll after they have their restaging? It was felt to be too complicated to try and enroll them at the outset, and that would likely limit accrual. Additionally, the main study question here is, if you are already in complete remission after induction, do you need a transplant or not? And so this more purely answers that particular question. The other piece that has come up considerably is what to do with these other folks. So if someone has a PR to anthracycline-based induction, should they be eligible in CR2 to randomize in this study? A lot of us felt uncomfortable with that, so that was not included here. But there, I think, is a considerable amount of opportunity to prospectively evaluate patients who do not achieve a complete remission with anthracycline-based therapy, but who are clearly interested in potential transplantation, whether that would be an allo transplant, some other version of salvage, and an auto transplant. I think we could come up with a variety of ideas. There are some exploratory objectives with MRD. As most of you know, there are not well-validated MRD analyses for T-cell lymphoma at this point, so we end up with a somewhat difficult piece. In terms of key inclusion criteria, I went through these. Again, it's those histologies, and you have to be in CR by Lugano in order to enroll. So the stats. So this is where we went back and forth quite a bit. We felt quite strongly that OS needed to be the primary endpoint for this study. If you are randomizing to therapy versus no therapy, especially in a disease for which, unlike in Brian's presentation, there is not good salvage options whatsoever, if that therapy has any degree of efficacy, it would be expected to result in an overall survival benefit. So this was the endpoint that we felt was necessary. It does include a much larger sample size. So again, we're at 380. There is additionally one other study that is being done in France. This is done in a somewhat different study design. I think the critical elements that are different is, first of all, the endpoint is a PFS-based endpoint, which results in a much smaller sample size. Their sample size is about 160 patients. The other critical difference is all these patients are enrolled at the time of diagnosis, and they are prospectively evaluated through their initial therapy, and then those who go into CR are randomized to transplant or not. So one of the questions had been, should we try and piggyback onto this study? There has been quite variable enthusiasm among the various committee members about trying to do an international collaboration, which historically has not been particularly easy to do. So I welcome questions, discussion, thoughts.
Well, this was at the end, but I guess the real question is, will people put their patients on this trial? Or will they continue to do what we've done for the last 15, 20 years, transplant everybody? What do you envision as being potentially attractive to patients who don't get randomized to transplant as an alternative?
Are you asking me that, or are you asking them that?
I'm asking everybody. I mean, so I think that all of us would consider transplant and first remission as being standard of care. You showed some retrospective data that looks pretty darn good. I was thinking, okay, what if this were me? I think I would probably want to do a relatively safe, non-lethal. Is it a one-to-one?
Yes. The internal discussion we had is that after the publication of this Dutch data, that trying to do this study would be significantly more complicated. Again, that was why the very first thing I said is that you guys had asked us for this, so we're delivering a product, and be careful what you wish for. But if we think that this is an important question to answer, which I think that a lot of people feel is necessary to answer in a prospective randomized way, here's the way to do it. And I would argue that a PFS outcome is not going to be particularly convincing. From my perspective, that would be simply confirmatory. We would anticipate a likely PFS benefit similar to what we've seen in large cell transplant versus no transplant studies, where there was a PFS benefit and there was no OS benefit.
What are the standard care numbers?
I don't have that off of the top of my head. This statistical design is for 10 patients per month, was the anticipated accrual.
Yeah, that would be really important to know, because if you're trying to capture 50% of the transplants, obviously that's different than 10 or 20%. So Megan, my only thought, are the patients that aren't being referred, centers who are in CR? Like, what's the community doing? I don't know any data on that. I mean, we don't get, how your thoughts are. We don't get these patients sent to us like in CR for transplant. I mean, that's not a very common occurrence. So I don't know what the practice patterns are around the country, but that might be more patients you could capture that aren't in the CR.
Well, they're not very common to begin with, but I think a lot of time we do get these people at the time of diagnosis. They may give them a cycle or two of chemotherapy and then realize they're T cells and send them to us because they don't know what to do, or they realize that CHOP is probably not the optimal therapy for them. A lot of times they send them to us because they think that transplant's the appropriate modality for them.
I mean, I think from being a non-transplant lymphoma doctor, I'm getting calls about these patients generally at diagnosis. Now, it's not everybody, and and a lot of them, they don't see me necessarily. It's just I'm getting a call. What do I do?
What do you tell them?
Well, I tell them an induction regimen, and I tell them they need to come and get a transplant evaluation.
This was at the SOSS meeting. This was one of the top proposals. Everybody said we need to know, is this useful therapy or not? I think that when, as you mentioned, when push comes to shove, people kind of back away. So maybe what needs to happen is a general survey to all the transplant programs in the country saying, here's the proposal, will you participate or not? And if the vast majority of centers say no, then probably we shouldn't move forward because the trial will never get done. Right?
More enthusiasm than we thought, but also they pointed out some things we weren't thinking about in terms of the design and the follow-up. So, but yeah, I'd be curious, what would the numbers look like if it was a 2-to-1 randomization? I mean, like that maybe would help an accrual. I don't know if that would help or hurt the numbers. I don't know.
I think you need larger numbers, but we can certainly ask. That's something to ask about. A 2-to-1 chance of getting transplanted versus no. Unfortunately, there's no alternative therapies available for patients in CR as maintenance.
Yeah. Are there any therapies that, I don't see a lot of T cell, but if there were some novel, really exciting therapies that you could almost build in for the patients that are not getting transplant to potentially salvage them and get them back to a transplant, I think that would even make it more palatable, but I don't know what those novel treatments would be right now.
I think the one thing, and you had brought this up before, is most of us at Relapse, if someone is an allo candidate, will plan on doing an allo transplant. And so the question would be, if you include in the study an allo transplant for people who either relapse in the observation arm or relapse or who do not achieve a CR with induction, would that be attractive simply from a payer standpoint? Because it often is not approved in patients who are Medicare or publicly funded. At least I don't know how it works here, but it's a geographical Medicare decision. We often have difficulty getting coverage for it. So if that were built in, would that make this more attractive in the sense that you could have allo transplant be built in as an option that would be covered theoretically by their insurance?
Or a single arm companion trial for less than CRs and for people who progress on this trial. You'd have to have good second line therapy to get them back into remission if they were progressing, or second line. Do we have anything like that?
I think probably you can give a gem-based salvage. It obviously depends on how they did, with reasonable response rates. The romidepsin and duvelisib in combination has a response rate of close to 80%. So typically if someone is chemo refractory, that's our go-to, assuming we can then get them into remission and send them to an allo. But we end up transplanting a fair number of these people allo transplants in PR, right? And they still do fairly well in PR going to transplant. And so it's a group of folks where there's a potent GBL effect.
So maybe get a group together, potential interested, and come up with a proposal to take to lymphoma committee. And, but I think that ultimately, if you have something for people that are either not randomized or are like in PR, like you said, to move on to allotransplant as a single arm study, then that might be more, make this trial more palatable. So what's the next step for the group? Are they going to proceed with this?
Well, so it's getting presented at ECOG next week and then at Alliance, I think, in a couple of weeks. And then we have a meeting afterwards and we'll figure out what the feedback is. But this feedback from this meeting was helpful. I'll incorporate all that.
All right.
Yeah, I mean, donors is like only randomizing with allo donors, so they relapse on the observation or they have a good potential treatment modality. Something like that would be definitely worth it.
And allow salvage therapy.
Yeah.
But with a specified regimen. Okay, well, we're over. Appreciate everybody racing through this, and we'll see you in April.